me to give a little bit of a presentation on all the orthopedics that's kind of coming to the hospital. Some of it's bread and butter, a lot of it's hip fracture things, it's a lot of new issues and what we're doing with joint replacements now, the aggressive treatment post-operatively, what we're doing, the average stays are shrinking down significantly. And what I see is a lot of times for orthopedics, there's a little confusion from the nurses because this person in bed 1 had a broken hip and they're toe touch weight bearing. This person had a broken hip and they can put weight bearing is tolerated and somebody put a pillow between their legs. And it's hard to know exactly what you do for what particular patient. So what I'm going to give an overview of is things that are for general orthopedics. Some different surgeon may have a different perspective on things, but most everything I think is vanilla. It's not specific to myself. So I titled this From Hip Fractures to Hip Replacements and More because I wanted to focus on the hip fractures. I think that's one of the big issues. Now, if anybody knows me, they know I'm an anatomy nut. You kind of stay out of trouble by knowing your anatomy. And the anatomy of the hip, for what you need to know from a nursing standpoint, is, I think, very, very simple. You're basically looking at a ball joint that's a socket and a ball. So you have the pelvis, and then you have the femur. So what you're seeing on the pelvis side is the acetabulum. On the leg side is the femur. What's really critical to a lot of my pointer isn't working, but to a lot of the discussion today when we're dealing with fractures is where does that fracture come from? And you'll have a picture to see that. Are we dealing with something that's involving the femoral neck where the blood supply is terrible and doesn't heal and it's very unstable? Are we dealing with an intertrochanteric or subtrochanteric hip fracture, or are we dealing with something that's impacted? So those type of presentations are really important to what we do surgically to make a decision. So hip fractures are a big deal. They're extremely common. They're continuing. Believe it or not, the incidence is actually going down even though the numbers are going up with the population, okay? So we're doing a little bit better as we're treating the osteoporosis that were, started hitting maybe when people were 50. So some of those people are now 65. Their incidence of hip fractures is less, but they're living longer, so the numbers are high. So if that makes sense to you. So we are doing a better job of preventing hip fractures, and a lot of it is what you see down at the bottom, which is the falls and the pre-existing medical issues that they have. So it is a chunk of change. This is the closest I got was 2012. It's probably up. It's probably more like 25 billion with the B. There's a couple of these words that are billions. And then you'll see why we try to kind of keep some of these costs down. So obviously morbidity and mortality. Hip fractures, when I was in my training, was 30% to 40% died within the first year. Now we're down to 15 to 25% within the first year as far as surviving that. The bigger issue is that second line that I see, that 50% of the people cannot go back to living independently. And so what we're going to see is we are grabbing a lot more patients. And what we're going to see is how the hospital is going to get into the home and adjust for the first time to, yes, you had a knee replacement. Let's look at your house. Let's say, get rid of the rugs. Let's put handrails here. Let's put rails in the bathroom. Yeah, I meant to do that. I meant to do that. Well, I meant to do a lot of stuff in my house, and it doesn't get done until something bad happens. So I think we're going to see where there's going to be a lot of outreach as we're grabbing people. Maybe they had a heart attack and they're going home. How is your house set up? So we may be able to prevent or get people back to their houses. I have talks once a week. You need to sell your house. I've lived there for 45, 50 years. Yeah, you're 73 years old, you're in decent health, but you live in a 2-story, 3-story home, and you can't do that anymore. You got to start planning for that. You get into a ranch style. So women, girls, you hit the top of the list. You get more fractures than the boys do, but the boys, unfortunately, have a higher mortality rate. So when men get broken hips, more of them are, unfortunately, have a higher percentage of demise.
Probably from their wives.
Yeah, absolutely. So hip fractures are very easily, again, I told you, it's where you get into the fracture level. So this is your femoral head. this is your femoral neck. So when it's at the head level, it has the word capital, so it's a subcapital hip fracture. When we're dealing with the neck, we call it a femoral neck fracture. There's different, we don't have to get into the different categories of it. And then what's important is when you get down to the intertrochanteric hip fracture. And all of this is determined on how we treat it for two reasons. Stability and healing capability. Okay, so those are the things that we worry about in terms of how we're going to treat somebody operatively. And almost everybody gets treated operatively. You know, there may be a case that somebody's got a non-displaced femoral neck fracture and they'd be really good on crutches or a walker and they won't put weight on it, and you might bless yourself and hope, okay, let's just hope you don't give out. But to me, when I can put, you'll see it, when I can put 3 pins in and a half-inch incision and it takes me 6 minutes and I know they won't get a subcapital displaced fracture where they need an endoprosthesis, I really talk everybody into doing that. So, like I just got done, determined level of displacement, how we're stabilizing the blood supply, and what particularly we do. So, in a subcapital hip fracture, there's basically two kinds. It's either stable and impacted, where the neck and ball jam together and they still move together, and then you can keep that where it is and pin it, or it falls off like an ice cream cone. And those are the ones that we'll go ahead and replace with a endoprosthesis, or now we're doing more and more frequently total joint replacements. Okay, so where that was never an issue, I'd say right now 20% of femoral neck fractures that are displaced are treated with the total hip. And again, getting back to the picture of it, so here's where you can get a subcapital hip fracture. Really, we should kind of be looking at this one more than the top picture. And if you look at the radiographs, here's the hip, okay, and here's the fracture line, okay? So I can see it clearly. When I point it out to you, you can kind of see where it's at. And what's happened is that's jammed in, and if you looked at it, they would move together. So that's a hip that wouldn't need to be replaced. It would just need to be pinned in position, and people do extremely well. And that would be it. This is just one of the trainers that I just did. Had normal x-ray, normal except for what I saw over here, and got a CAT scan. CAT scan's theoretically better than MRI for bone. That was normal. And finally, I said, I don't buy it. We got an MRI and it showed he had a fracture. And so what I did is I put in 3 screws, and you see those are parallel, and you'll see that on one of the devices, and that allows, if that wants to settle, it settles in the plane that I want it to go. So it kind of can impact further if it wants to, as opposed to if the screws are all different locations. So a stable subcapital hip fracture, an impacted fracture, usually those go to pinning. One that looks like this, so does that look like that fracture? The answer is no. And if you look at it, boy, there's no femoral neck. The reason there's no femoral neck is the ball stayed there and the hip turned like this. So if I could turn the hip out, you'll see the neck and it'll look like that where it's just split. So this cannot be pinned. It's not stable, so it needs to be replaced one way or another. And so what's really neat is, I like history of orthopedics. This was the first joint replacement we did. This is an Austin Moore endoprosthesis. I did them when I was here. I came in 1992. You get 2 sizes, small and big. They weren't cemented. Dr. Turner, who is here, could probably do them in 20 minutes. And then this is the upgrade of this. This is a bipolar, and I'll show that to you shortly here. And the bipolar says, if you're going to do that, let's see if we can give 2 areas of motion, just instead of where the big ball is, where it can grind away at the cup. If we let it move over here, and we let the ball move inside of it, maybe it'll decrease the wear. And I have a gal, 2 months after I was here, male carrier, a male truck driver carrier. She has to be 350 pounds still. And in 1992, I did a bipolar. I said, honey, it'll probably last about 5 years. But she was 47 years old. She still has the same bipolar hip and doesn't have any trouble with it, which is just shocking. Okay? And I'll maybe show that to, let me show it to you now. Does this show up on your screen? Mm-hmm. So basically, if we're going to look at the Austin Moore kind, let's just assume this is one piece of stem where you had the big ball and it was part of the stem. okay? Then we graduated to the endo head, where we said put a stem in, and then put that big Austin Moore, and it would articulate with the socket. And then what we graduated to, and I can't separate them. Nope. Okay. You wonder why they don't come out. And this is a stem that has a ball on the neck of it, and then it goes inside of this ball, which has its own plastic. So what happens is the little ball moves inside the big ball, and the big ball moves inside of the socket. So you get bipolar. The interesting thing is I'm starting to do this with hip replacements. So you put a socket in, and you put the little ball on, and then you put the ball on a plastic, and then you put the plastic in here. So it's still a dual mobility, but the same kind of idea. You have stability because you got a big head, but you have more mobility. So it's amazing how things keep coming around, okay? So that's that. And while we're looking at it, so we don't have to come back to this, this is a hip replacement. This is modular. This is kind of I use, but most of them have a neck on it. You put the head on it. This is a ceramic head. It's pink, girls. Even the boys get the pink one. And then they go into a fixed cup and sit in there like that. And then so they articulate. And the only bad thing about this is they can pop out, right? Because you move around and if it's not too tight or the angle's not right or whatever happens, muscles are cut. But this is a traditional hip that we're doing right now today. So this is a real hip. So this is, I just did one before I walked in here. This is exactly what the individual got. They got a metal cup that goes in there, the bone goes in there. They get a plastic liner, which we've now, sheesh, in my 24 years, we're on our 5th liner now as far as improvements go. And then a ceramic ball, modular neck, and all of this is bone ingrowth. History. When I came in 1992, everybody was cementing hips. Now, nobody is cementing hips. Okay? Now, knees, 80% of the people are cementing knees. And I don't cement them, but I think we'll come around to everything's going to be uncemented because biologically, once the bone's there and grows in, it doesn't loosen. So that's the implant side of these hip fractures. So when you get a femoral neck fracture, which is that range right below the neck before you get to the intertroch, there's no blood supply once you fracture it. It's basically dead. It can't heal. Women, for femoral neck fractures, for intertroch fractures, 3 times more common than men. And the only thing you can do is an endoprosthesis, a bipolar, or a total hip. And this is what the radiographs look like. This is, let me go backwards. This is a total hip. So this is a great looking x-ray. The cup's in perfect position. You see there's a screw in there. It's stable. I know whose this is. And then there's a stem that goes down here, and then the ball goes on there. And then that ball moves inside of the cup, which is fixed to the bone. Now you look at this one. Let's say you have the same kind of stem, and you see some idiot put that ball or that cup, it looks like a cup, horizontally. Well, it's not a cup, it's a ball. So it's showing you that this little ball in here is moving inside of the big ball, and the big ball is moving inside the socket. So this is a bipolar, this is a total. So the argument we make in our world, what's the advantage of that as opposed to this? You know, that one will wear the acetabulum out, they'll start getting groin pain, and in 5 years, 8 years, they got to come back and they got to convert it to this. So we're leaning more because we are so good at what we do, okay? We used to put central lines in, oh my God, it was like a, big deal. Now we pop them in and not an issue because we're so good at what we do. So same thing with orthopedics, we've improved significantly. Then the last part, I'm not going to get into subtrochanteric fractures, but the last fracture is an intertrochanteric hip fracture, and we categorize them in 2 fractures, 3 fractures, or 4 fractures. All of those need to be fixed. The old nurses in the room will understand what an ambi is. Don't ask me what it stands for, but an ambi is a compression screw and plate. And then now the thing that we've been doing probably for the last 15 years is an IMHS, intramedullary hip screw. Same design, and I'll show it to you, but instead of exposing and putting a plate on the side of somebody's femur, now you make a little incision, you drop a rod in there, and you do it all almost percutaneously. So here's what the anatomy cartoon picture looks like. Here's the fracture intertroche. Why is it intertroche? Because there's a lesser troche, there's a greater troche. It goes in between, hence the name intertroche. Wish I invented it. And this is lined up perfectly. So you can have them where they're not lined up perfectly, where the lesser troche is off or the greater troche is off. This is kind of similar to what that is. Here's the ball and socket, and here's the fracture line. Here's the fracture line that goes through there. So it's in good position. You have to stabilize it. If those are displaced, we line them up in the operating room by how we move the foot and the leg, and then we go ahead and fix those. Here's kind of the guide that shows you a 2-part, 3-part, 4-part, and then really bad. And this is a 3-part. So here's the one piece. This is the ball and the femoral head and the neck. This is the shaft that comes down here. That's the 2nd part. And here's the lesser troche, the 3rd part. Okay? And then if the greater troche was up, this actually might be a 4th part. It might be a fracture here. It's a moot point. It's, got to be fixed, and we treat that once we get in there. So here's the rationale for what a ambi hip screw is. So what we do is we put a guide pin in here. We put a plate and a barrel. That's one piece. And then through that goes through the screw, and then we actually tighten it with another screw and pull these together. So this is like the barrel of my pen, my ink cartridge is like the screw, and we actually compress that, and when the patient walks on it, they compress it further. So this screw is allowed to slide through the cylinder that's there, hence the compression aspect. I compress it in the operating room, the patient can press it further when they're walking. So, and that's what it looks like on the side view. But you have to do this much surgery, and bigger incisions, and everybody likes little incisions now because we're all so vain. And then this is the new generation of it. It's the same technique, except what you do is you drop a rod down here, and then through the rod, you put that compression screw, and then you lock it from above. That won't let it turn, but it'll still let it slide. So this person, you see the fracture line here, and there's a little bit of a gaposis. When they walk on it, and you see them back in the office, this screw here, instead of being here, it will probably stick out a little bit, doing its job, okay? When you had an intertrochanteric hip fracture, you had an 80% chance of dying. Just write the will right there, I will be dead. Enjoy my house. It's rare now that we see the mortality from this because of what we talk about coming up, nursing, right? I can do this, and I can do a great job, and you guys can kill my patient, right? Because they're not moving, they're not doing that. I can do an okay job, and you can make them look like rock stars because you get them up and moving, okay? So this is an important part of the talk. We're still going to come to how you treat these on the floor differently. Those of you guys that know me, I'm all about the patient. It's all about taking care of that entire patient. You'll see what I mean by that. It's not Mrs. Smith with a hip fracture. It's Mrs. Smith that brings with her a ton of baggage. Okay, and she's, we'll get into it, comes with a lot of other issues that she causes. Because most of these folks are elderly, right? So, how many people come in and, I was just out, at my polo match and I broke my hip, That doesn't happen too often, Pain control options on how we're treating people, the obviously critical issues about DVT prophylaxis, decubitus ulcers, and obviously what has changed and revolutionized everything is getting people up and moving and getting them out of a hospital where all the bad things can happen in terms of bugs, right? So treat the entire patient. This is what everybody comes with. They come with diabetes, they come with dementia, COPD, all kinds of vascular issues. They couldn't walk to begin with, and then they fall down, and then we're going to turn them into, Bruce Jenner in his good day when he was a, triathlete, okay? It's not going to happen if they got Parkinson's and that kind of stuff to begin with. So you want to look at the entire patient as far as that goes. Pain control. I'm going to write a paper here about the patients we have here. Me talking to the nurses, they're not getting pain medicine. Well, they don't need it, Dr. Palutsis. Well, that's great. So less is better because you don't want to make them gorked out. That's why when what I push for is, boy, if they have less pain, they do better, because they're remembering things, they're not, somnolent and everything else. So less is better. I hope nurses, when we write 1 to 2, means you can give them one. It's okay to give them one Vicodin. They don't need two every time. Other ways in which we're treating, we went through a course of IV Tylenol for a while. The Toradol has been a wonder drug, as a pain control, as an anti-inflammatory. Ice is critical. Positioning. Just think about some of these people can't move. And all they need is to lift their leg up, put a little pillow underneath their knee and rotate it out. And oh, God, that feels so much better. Then they're not, moaning and groaning and saying how miserable they are. The pain pumps, anesthesia we're doing, and epidurals, spinals, whatever the case may be, some of the blocks that we do are all part of that aspect. That only went once, did it? Okay. DVT prophylaxis, we do a phenomenal job here. We absolutely do. This was a big deal in the past, and it's not as much of. I just had a girl I did a meniscus repair on. She's 3 days getting her brace off, and she has a blood clot in her leg. I said, I think that's the first time, of course I can't remember everything, that's happened. You would think it happened a lot, but she's on birth control and those risk factors. But this is key. This is something that we need to be able to do. We need to be able to make sure we prevent this. Obviously, the SCDs and the TEDs are critical. I'm starting to do the SCDs at home now, which I think is a very, very important aspect of it. The best thing is getting them up moving. So if they have less pain, they're more likely to get up. If they have the ability that, oh man, I can move and walk down the hallway, that's what's kind of keeping them from getting the DVT. And we have chemical ways to treat it. Obviously, all you guys know that. Sue and I talked about the aspirin. It wasn't approved. Okay, Medicare writes all the rules, and of course we're not real doctors anymore unless Medicare tells you are. You can't use aspirin. Well, now I got 1,500 people just on aspirin twice a day, and not one of them has had a PE. I had back surgery. I had a PE. Thank you very much. But now we're seeing that. I'm using that on my knees now. But big studies, the Hospital for Special Surgery is now using aspirin because all this other stuff, you guys hear me moan about all the time. The Arixtra, the Lovenox, heparin, it just causes so much bleeding post-surgically, and we're talking different than on a medical floor. And then just be aware. You got to kind of keep checking, squeezing their legs and that kind of stuff to see where they're at. This is a huge thing, and I think we do a phenomenal job of this, is to avoid decubitus ulcers. Again, how do you avoid decubitus ulcers? Get them out of bed, right? Don't let them sit in a bed and a chair or whatever and stay all together. Again, we're talking about orthopedic patients, okay, as far as this goes. So 90% of these are coming in as secondary diagnoses. They are avoidable. Everybody, I'm sure the nursing staff is just preaching that to you guys ad nauseum. It costs a couple of bucks a year to treat a decubitus ulcer. The average range, I think this is low. I don't know. Does it seem low to you? So 43. I heard it was more closer to 80. As far as what it costs to treat a decubitus ulcer. There's a nice statistic. Invite your local lawyer home for dinner. 17,000 lawsuits. A year annually just for that alone. Because what does it say to somebody in a court? You gave me something that I didn't have when I came in, and it was preventable. Right? End of story. Right? Nobody gives all the other credit about all the other, things that are in there. And this is my pet peeve. Don't just document that, I documented there. Just make sure you turn the patient. Make sure they don't have a decubitus ulcer as far as that goes. Okay? This is my favorite slide because I just see it in the nurses' faces, the new nurses. Oh my God, we got an orthopedic patient on our floor. What are we going to do? How do we move them? And it's an issue, but it's really kind of, I think I came up with a simple slide for that. And if you look at the two factors about this, you're looking at what is the stability of the fracture and what is the stability of the joint. And they're backwards. So when you have a stable fracture that is treated with a replacement, an endoprosthesis or a total hip, that is a stable fracture because guess what? The fracture's gone. We're not asking it to heal. But it leads to an unstable joint because you got an artificial joint. Now, if you have an unstable fracture, I put 3 pins in there, I did an AMB, I did an IMHS, I got to let that heal. So that's an unstable fracture, but the joint's stable. So you can twist that patient all over the world, not an issue. Okay, so if you think about it, why am I on kid's glove because this joint's unstable, okay? Or why are we worried about the weight bearing status because the fracture's unstable, okay? So when you do a hip pinning and a plating, we gotta let the fracture heal. So we're partial weight bearing, toe touch weight bearing. Very rarely should you be non-weight bearing. Because non-weight bearing, having to lift my leg off the ground like this, puts more weight across my joint than resting it on the ground. So you'll never see me write non-weight bearing. It's always toe touch weight bearing because there's less joint force across the hip joint or the knee joint by letting that foot rest on the ground or gliding. Okay? Whereas I think most everybody with the hips, people weight bearing is tolerated with a aid. Okay, so with a walker or whatever, because it's a stable. You're not worried about the fracture. Fracture's done. It's healed. Okay, there's no fracture. We cut it out. Now we're just letting the tissues around heal and the patient get back their functional aspect. So, are we good there? Does anybody have any questions about moving, about what's the difference, X, Y, and Z, hardware, not hardware? Any questions you guys have? We're good? Okay, so then total hip approaches. Okay, a lot of you folks, have been here as long as I have. So I do a different approach, okay? It's still revolutionary. Every hip was a posterior approach. The only time we did an anterior approach was when we did kids. And then somebody came up with this crazy idea, wouldn't it be great if you could do a hip replacement without cutting muscles? Well, that's never going to happen. Well, it's happened, right? So we've done 1,500 in this hospital alone. That's more than anybody in the world. But the standard approach has been a posterior approach, then there's the anterior approach, then there's an anterior lateral approach, just a variation of that, and then there's a 2-incision approach. I'm not going to tell you one's better. That's not what the topic of this is going to be. But they're different areas in terms of what you have to do to protect a patient based on that, okay? So the posterior approach is the way hip replacements were designed initially back in the 50s, okay, and 60s. So that's how the guys that learned how to do hips taught guys to learn how to do hips, taught guys to learn how to do hips, taught guys to learn how to do hips. Everybody did them posteriorly. The only bad side about that is you have to cut the external rotators when you do the hip, and then you have to sew it back on. Now, when I was, you guys know what a blue surgical towel is? It's got to be this long. What is that? 18 inches long or something like that? That's the incision we did in Chicago at Northwestern. We make that incision, we'd sew the towels in, because who cares? The wound heals, side to side, not end to end. Who cares how big it is? Holy camole. Can you imagine that now? You're looking down at the knee and the hip at the same time. Why did it go all the way down on the foot, And you don't see that now, okay? Doctors here, we're doing little incisions. You still have to go ahead and take that abductor mechanism down and then repair it. And this is important. So if you have a posterior approach to the hip, okay, all you older nurses, you always told them, don't turn your foot in, and don't cross your leg over, and don't bend your hip past 90. That's that. Okay, that's the posterior approach. Okay, even now, we're getting a little bit lax on that. Maybe you can do this and do that, but that's historically what it is. That's why it's different than when I see my patients or an anterior approach. So when you look at an anterior approach, that's the hot baby. Okay, nobody can do a 2-incision. We'll all do an anterior approach. Okay, because that must be the way it is. So we're doing anterior approaches. We did that to say, well, that way we won't have to worry about dislocations. People can sit down and sit in their lazy boy and not have to worry about dislocating. So you don't cut a muscle. You have to strip a lot of muscle, but you're not cutting it. And on that, you're avoiding external rotation. You don't want the hip to pop up through the front of the hip, okay? So you don't want that leg going out, and you don't want that leg going behind you because it can lever forward. You can bend them as much as you want. You can bend them 120 degrees, okay? The posterior approach, that's when we did the pillows. Do we still do that? Anybody use an abduction pillow?
Every once in a while.
Every once in a while. So that's where you kept the hip apart so that you didn't cross it over. The 2-incision, obviously, when I started doing it was 2002. It doesn't cut any muscle. It's extremely gentle to all the tissues. You get much quicker recovery and return to work and that kind of stuff. But you're still avoiding external rotation. You're still avoiding extension. I don't give any other precautions. I wish therapy was here so that they could have a little dialogue, because basically I say, okay, this is what therapy said. And then when I see them in the office in 10 days, I just forget everything. All I want you to do is just don't extend your leg backwards and don't act like, you know, Charlie Chaplin, excessively out or excessively in. But I don't give any restrictions. So that's the hip. Is there anything particular you guys have questions about the hip, or you think that any of the other nurses would, or comments, since it's going to be on a videotape form? So if we're good, I didn't come to talk about knees because knees are knees. You know how to get a knee up, right? There's not a whole lot of difference. We let them weight bear. So as far as knees goes, here's the difference. We either cement them or we don't. Okay, I'm an uncemented guy. Almost 80% is cemented. Whether you replace the patella or not, most everybody does. 98%, 99%. I don't. So that you're allowed to kneel on it if you don't have an artificial kneecap. Started doing custom cutting blocks about 7 or 8 years ago. That is saying, instead of using these long rods that I put inside people's femurs and tibias and getting the alignment, now we can do that with custom cutting blocks that tell us how to cut, where to cut, and yet helps with the alignment, less drill holes, less blood loss, less pain, but you're still putting in an implant that some engineer designed. And now what I'm doing since the end of last year is now they're making custom implants. So the wonderful thing about that is you have less bone loss, much less pain. You're seeing it on the floor that every single person, we've done 85 of them, except one has gone home in a day. The average time before that was 48 hours, which was pretty good, I thought. And so I think everybody allows their knees to be weight bearing as tolerated with some type of walker or cane. So, and you move them around, you wiggle them around. There's no precautions for them. And then where we're at with the future of joints. That first statement, you got to take that and you got to be proud of that. Okay, we have come a tremendous way in my 25 years. In the last 10, 15 years. Everybody stayed for 4 days. Everybody went into rehab. Everybody was gone from their home for 2 weeks, 3 weeks. Everybody was in therapy for 12 to 16 weeks. They didn't get the management, the aggressive treatment we're doing now. The future is, what are we doing for length of stay? Okay, I'll go on record. I don't believe in outpatient total joint surgery. When I see a patient in the morning and they tell me the therapy see you and they say no. And I'm like, right when I'm ready to get upset, the wife says, honey, they saw you yesterday, you were walking around. They walked you in the hall. They don't remember that, okay? So what are they going to do when they go home and they can't remember what they're to do or not to do? I say it all the time. What if you have a guy that 64 years old, never had a problem with urinating, and all of a sudden he's home at 10 o'clock and he can't pee, and he's from an hour and a half away. His wife's got to try to get him in a car to get a Foley in, and all that kind of stuff. So I don't see it ever. Of our 1,500, I don't know I can't remember exactly what the number is. It's like 93% of them go home the next day, which is ridiculous. I mean, that's been going on for 14 years I've been doing it. That to me is as good as we should be. I don't think we should shoot the next level because I don't think it's safe for a patient unless you have a nurse live with them. Early mobility is unbelievable. We take that for granted, what a difference that's made. Pain management, a lot of places, we're not as into it as other places, and the cocktails that they give them and this and that and everything else. I think we do good surgery. I don't think that's as much of an issue, but that's where things are designing. The implant design, where we're now on custom implants, which I'll show you here in a minute. I think we're going to be in nanotechnology, where when I put a knee in, it's actually going to give me feedback, just like a pacemaker does. It's going to tell me, what the pressure sensitivities are on the inside, outside of the knee. A lot of guys in orthopedics are fighting it. Why? Because it tells you whether you do a good joint or not. But to me, I want to know, is the pH in that knee changing? Does this person have an infection brewing? And to know that ahead of time is going to be really, really critical. But if you look at it 5 years from now, our knees are going to be custom implants, designed patient-specific, it's still an exciting time. So I am going to go over a couple of things here. I think I'll turn the lights on and then see if you guys have any other questions. And of course, I got to give you the thank you slide.